This section is all about the assessment of the knee. Part 1. The learning outcomes for this week's assessment of the knee will involve revising the main injuries occurring in this region, applying and understanding the main assessment procedures of the knee, both subjective and objective, and then following through on further objective testing procedures. Just to review briefly, already you should know some of your anatomy of the region, and just to remind you and to clarify some of the pathologies that may occur, it is useful to consider in subheadings of ligamentous injuries, meniscal injuries, bony or osseous injuries, those injuries or problems associated with the patellofemoral joint, the osteochondral region of the tibiofemoral joint, and any musculotendinous problems which may occur. Initially, we will look mostly today at the patellofemoral joint. This is the joint between the posterior surface of the patella and the femoral sulcus. It is most prominent and active during knee flexion and extension. So, let us consider the potential problems and pathologies that occur within the patellofemoral region. One of the most common diagnoses that people may be given by a medical professional is patellofemoral joint pain syndrome, or PJPS. It's a global term for any pain resulting from the patellofemoral region. This is also classically linked into the large umbrella pathology of anterior knee pain, which is also commonly associated with the patellofemoral joint. Chondromalacia patella is a more severe breakdown of the cartilage on the posterior surface of the patella, and it's most commonly seen in young girls. There may also be patellar instability or dislocation, most commonly associated with those of hypermobility, and bursitis found within and around the knee. So let us consider what we need to do in terms of assessment. A thorough assessment in terms of the subjective questioning of the patient is ideal. We need to first of all identify, are there any lumbar or pelvic involvement? Is the pain actually referred from the lumbar spine through the femoral nerve? Are there any pelvic instability issues which may be affecting the knee and the loading and mechanics of the knee joint? Secondly, are there any chronic loading problems in the lower limb generally? This may relate to either the pelvis, as mentioned just now, or the foot. We need to identify the structures which have been affected, what their pain behaviour and nature is, and just check the special questions which may relate particularly to the knee and indeed the patellofemoral joint of clicking, locking, and giving way. When considering the other points of the subjective assessment, let us go through these in a little bit more detail. The subjective will always follow the same and similar subheadings that we have considered during the subjective assessment for any other joint, hip, ankle, or wherever. There should be some extra questions though which are associated with the knee particularly. Specifically ask the client to expand upon the mechanism of injury. Was the foot in contact with the ground? Were they weight bearing at the time? Were they twisting? Was there any loading issues, or was the foot unstable? Was the ground slippery? All of these have a bearing on what the outcome of the injury might be. What about the swelling? Did the injury swell at the time immediately, or did the swelling develop over a 24-hour period? This will help to differentiate between a more severe hemarthrosis and a less severe but still notable edema or swelling within the joint itself. Is there any noise at the time of injury, such as a pop, which might indicate the rupture of a ligament, such as the ACL? Or is there any grinding or crepitus during the movement that aggravates, such as going up and down stairs, hearing a grinding or crepitus? Is there any locking or giving way? And locking can be sometimes known as pseudo-locking, and it's important to differentiate between actual and pseudo-locking. Actual locking is when the knee locks in a position mid-range of flexion and extension, and it is impossible for the patient to unlock their knee without potentially going to A&E to have the situation reversed. Pseudo-locking is where the knee feels as if it's locked, but can actually be wriggled free with medial and lateral rotation. Has this occurred at the time of injury or since? Functionally, it is useful to ask about what brings the pain on. Do they like weight bearing? Is it mostly on stairs, going up, coming down? What's rotation, cutting manoeuvres, twisting like? What is the pattern of their pain? Note the sensitivity of the structures of the knee may vary considerably. So let us now consider the objective assessment of the knee. When doing an objective assessment, you will always consider the following subheadings. First of all, observation. This will involve a postural assessment involving both the spine and the lower limbs. Next, it's important to consider the active range of movement of the joint that you are assessing, and potentially the joint above and below to clear those areas. You may also need to think about passive overpressure. What does the end feel like? And this will be dealt with later on for the knee. Resisted testing is a way of testing of the muscles, and then specific tests may be done for the joint in question, such as for the patellofemoral joint, gliding of the patella relative to the femur. Other special tests and functional tests will be included. It is also important to have a look at any scans or x-rays that the client may have brought with them, or to note down to order them if you feel necessary. First of all, let us consider observation of the patient. When observing the patient, it is always useful to look at from the front, behind and the side. You may also like to look at them doing functional actions which might aggravate their pain, such as walking, squatting, stairs, knee dips, one-legged standing. Look at the tibiofemoral alignment and posture as well. Referring to the pictures below, can you see any of the dysfunctions here, such as squinting patellae, where the patellae seem to appear to squint inwards? Do they have genu valgum or genu varum? Or indeed, are the knees hyperextended, as you may see in some patients with hypermobility? Also look at the patellofemoral alignment and posture. Next, it may be useful to consider in a little bit more detail the mechanics around the knee joint and the effect of the hip on the knee joint. We've dealt with the position of anteversion and retroversion in the hip assessment, but it's also appropriate to consider the hip alignment when assessing the knee and the effect it may have on the knee joint mechanics. Craig's test is a useful test to determine whether there is any excessive anteversion or retroversion. It's also useful to look at tibial torsion to see if there is normal position of the tibia, or whether of 15 degrees, or whether this is excessive either into external rotation or internal rotation. Finally, always check for swelling. It may be useful at this stage to determine whether the swelling is intra-articular and named an effusion, or extra-articular where it is named edema. Next, it is useful to consider range of motion. Within the knee joint, we have various ranges of motion: flexion, extension, medial and lateral rotation. First of all, it's important to consider what position you will be assessing their range of motion. When we look at knee flexion in supine, it may be very different to that in prone. This is worth considering why and how that may affect their pain. Check and measure the range. Feel for the end feel, check for symptoms such as pain, but also for spasm and other problems, weakness that might occur. You may feel it's appropriate to combine movements if you haven't already managed to elicit the pain, such as flexion and medial rotation, or extension and abduction. When considering the end feel of the knee joint, this may help you to determine whether the end feels are normal within your client. During knee flexion, a normal end feel of softness is felt at about 135 degrees. The softness is due to soft tissue apposition of the calf versus the hamstring muscle. Bringing the knee into extension, it should go to the neutral position, and normally you will note up to 10 degrees of what may be termed hyperextension. This is a firm end feel, more bony in its nature. When considering medial and lateral rotation, you will also determine a firm end feel. Consider the joint and the range of flexion that you need to determine medial and lateral rotation. Next, it's appropriate to move on to your resisted muscle testing. For most joints, resisted muscle testing would occur at the mid-range of the joint, isometrically. In the knee joint, and particularly with the patellofemoral joint, it is useful to assess the extensors in different positions to see their firing activity. You may like to look at the extensors in full extension, at 30 degrees at flexion, and at 90 degrees flexion, keeping an eye on what the patella and the tracking of the patella is doing at each of these positions, and also relating that to their associated pain. The flexors of the knee is also potentially useful to determine at different positions in range. Add on the medial and lateral rotators to differentiate between the hamstring that may be involved. You can also isolate medial and lateral rotation as well. Move from isometric to isotonic if you feel it's appropriate, and always note down any pain, strength and quality of contraction, and tabulate your findings. After doing the muscle strength, it is then appropriate to do the muscle length tests. Muscle length testing may involve the Thomas test, which is useful for determining the length of rectus femoris and differentiating with the other hip flexors, the hamstring muscles, where you can use the straight leg raise, or the 1990 test for the hamstrings. ITB test may be differentiated with Ober's, and finally gastrocnemius. When assessing the patellofemoral joint in particular, it's useful to look at the position of the patella within the knee joint itself. Some of the dysfunctions that you may see of the patella are medial or lateral glides, rotations, medial or lateral tilts, and anterior or posterior tilts. This change in mechanics of the patella, position of the patella, may affect the mechanics of the patellofemoral joint. This is an example of a syndrome called miserable malalignment, where you can see squinting patellae associated with internal rotation of the hip, internal rotation of the tibia, and pronated feet. Particularly associated with the patellofemoral joint is assessment of the Q angle. The Q angle is the line bisecting the patella tendon and that line relative to a line passing from the ASIS to the centre of the patella. Normal values for this are 10 to 15 degrees in men and 10 to 20 degrees in women. An increase in the angle of the Q angle gives an idea of patellofemoral joint dysfunction.